become the directive for our national cancer project, cancer treatment goals, to personalize our medicine for the patient and for the specific tumor they have. Lung cancer used to be thought of as a monolithic entity, that one lung cancer was another lung cancer was another lung cancer. We're increasingly able to subdivide lung cancer and to identify what are the causative changes that led to the development of the cancer. For example, I'd say that the best example in our current understanding is a mutation in a growth factor receptor called EGFR, epidermal growth factor receptor. When this receptor is mutated, it is turned onto the on switch all the time. So it's always telling the cell, grow, grow, grow. And that's essentially the primary change that leads to the development of cancer. I think that the identification of what's driving the cancer, of the cause of the cancer, then tells us a silver bullet could be developed to block that mutation, to block that change in that individual's cancer. You could imagine that there are lots of different ways to slow down the growth of a cell, but if you can identify the single causative change in that cell, blocking that event would be the most effective and probably the least toxic of treatment options. And that type of approach to cancer treatment has proven very effective in other cancers and now in lung cancer also. Chemotherapy tends to have more side effects than the newer targeted therapy, but it also is a mainstay of our current care. I think what a remarkable development of the last few years is a better understanding of which patients should get which chemotherapy. So this is targeted treatment for the specific patient, but even using our older agents. One of these drugs, pemetrexed or Alimta, has been found to be remarkably effective for a subset of non-small cell lung cancer patients, those with adenocarcinoma. And it is also a very well tolerated drug. I would say it's one of our better benefit to side effect ratio treatment options. We conversely know that other drugs, such as gemcitabine or Gemzar, are more effective against the other most common type of non-small cell lung cancer, squamous cell. We are now increasingly able to identify which patients are most likely to have benefit from specific chemotherapies. Therefore, we're less likely to give a patient the side effects of chemotherapy without benefit. So this is also an advance that can be called personalized medicine, even though it's using chemotherapy, not the new targeted drugs. And lastly, we're learning more and more about how to combine these two types of agents, both chemotherapy and targeted drugs. There are two treatments in particular. One of them is bevacizumab or Avastin, which blocks blood vessel growth. And the second is cetuximab or Erbitux, which is a way of blocking EGFR, which I mentioned before. We are increasingly understanding how to combine these drugs with cocktails of chemotherapy. This improves the response rate, the percentage of people that will get a shrinkage of their tumor on treatment, and the length of time that the tumor will be kept under control. These combinations are allowing us to be as effective with as little toxicity as possible. I would say what's really remarkable is that now my goal for a patient is to feel better and to live longer on an effective treatment. There are numerous new approaches to that. The simplest is identifying the subtype of non-small cell lung cancer. Adenocarcinoma patients are known to respond more frequently and more safely to certain drugs such as pemetrexed or bevacizumab. And conversely, squamous cell patients are understood to have too high risks if treated with a drug like bevacizumab, but to do quite well with drugs like gemcitabine. That is a new understanding of lung cancer at its most basic level. So now we frequently have to ask our pathology coworkers to specify which type of lung cancer a patient has. The newer developments are on the identification of genetic changes in the tumor cells to look for mutations in growth factor genes, growth factor receptor genes, or in understanding how the tumor cells may be dependent on certain factors in the cell and in the body. This helps us identify what caused the cancer and what treatment, what targeted treatment or what silver bullet may be most effective for the patient. Then the new technologies are becoming more and more impressive. We are understanding that most cancer patients have tumor cells that are in their blood called circulating tumor cells. Not only does that help us follow how a patient is doing and how they're responding to treatment, but the hope is that we could test those cells to learn more about the patient's cancer. And this is really the forefront of diagnostic technology. To be able to learn about a tumor without doing a biopsy, to be able to look for changes over time without multiple invasive procedures, really may help us identify proper treatments, look for emerging resistance before it becomes clinically significant, and then identify the appropriate adjustment to treatment.